So we're going to take a look at medical management for diabetes mellitus. Treatment of diabetes depends on many factors. This includes the type of diabetes the patient has and involves most often a combination of the following factors. In medical management, we're going to be looking at several factors here. In diet, which is a major component of the treatment for every patient with diabetes. Also, weight loss. Any type of weight loss improves the patient's body's use of insulin. Exercise helps metabolize carbohydrates and control blood sugar levels. Insulin, and no matter what form you're using it, whether it be an insulin pen, a jet injector, an insulin pump, or even IV. Insulin is used in those patients with type 1 diabetes to replace the insulin that is no longer being produced from the beta cells. Oral anti-diabetic agents, also known as hypoglycemic agents, are used in those patients with type 2 diabetes. It is used to increase cell receptivity. So it increases the cell receptors. And it is used among patient populations who meet a particular criteria, and we will discuss this a little bit more closely later in the discussion. Then we can look at pancreas transplantation. That comes with some risks. And then we have islet cell transplantation, which also comes with some risks. So, diet, weight loss, and exercise. Diet formulas are dependent on the patient's sex, age, height, weight, activity level, the occupation they're in, their state of health, and cultural background. These patients should be referred to a nutritionist, dietitian, or a diet educator. Again, diet is a major component for all diabetes and is specific for each patient. Weight loss program is important if it is indicated. Exercise is tailored to the patient's need and lifestyle. The perks for exercising is it reduces the need for insulin, it metabolizes carbohydrates and controls blood glucose levels, it improves circulation and improves muscle tone, and controls cholesterol and triglycerides. In this particular process, the skeletal muscles allow the muscles to take in glucose from the blood, which is independent of insulin. So exercise is really important for this group. So insulin is prescribed in units. Insulin is never prescribed in milligrams. The only dosage that you will use is in units. Typically, 1 milliliter of insulin equals 100 units of insulin. Again, 1 milliliter of insulin equals 100 units. Subcutaneous fat areas are to be used are often. That's typically what you use. Subcutaneous or SQ, and that's typically where we use. And we typically it's best in the abdomen. However, we can use the back of the arm or the thigh. Injection, again, this is the needle, and we work with the abdominal area. And we want to tell patients when they're using the abdominal area for self-administration that these sites require rotation in order to avoid lipotrophy, a breakdown of the subcutaneous fat, and lipohypertrophy, which is the buildup of the subcutaneous fat at the site of the insulin absorption. So again, insulin injection via a needle. Then let's look at the insulin pen. This has a cartridge, and it's usually from 150 to 300 units of insulin. It has a disposable needle, and the patient checks their capillary blood glucose, and whatever they're supposed to be administering, they just dial it in. If it's 3 units, 10 units, they click the dial, and they select the required amount of units, and then just self-administer. A jet injector uses high pressure and rapid speed to instill insulin through the skin. So there's no needle that is required. These are quite costly though, but they eliminate pain, they eliminate a needle stick, and disposing of the needles. So again, these are quite costly, but they are quite beneficial at the same time. An insulin pump. This administers insulin via continuous infusion. Patients really have to be compliant and really work hard to control their diabetes for this. There are three components of the insulin pump. One is the pump itself. You have pump tubing, and then you have a needle. The needle is inserted in the subcutaneous tissue of the abdomen. Remember, this is very important for an insulin pump. These pumps only work via the abdomen and can remain in the same site for up to 3 days. Pros and cons of the system are located on page 866 of your Med Surg book. As far as nursing practice, I think it's important to know patients present either to your ER, maybe to an urgent care facility or anything like that, and they may be looking like they're in diabetic ketoacidosis, or they have high levels of blood sugar. One of the questions is always check the needle on the pump. These little needles can kink because they're there for a couple of days, and we're running around, we're laying in bed, and so it's not out of the ordinary to see a patient come in with DKA. Their levels are huge, and then we find that the pump or the needle was kinked, so they weren't getting their insulin properly. So let's take a look at some of the insulins. This table is from your pharmacology book, and I will talk about a little bit of a discrepancy from your Med Surg book, but we're going to go with your pharmacology book on this. So for rapid-acting insulin, we have Humalog, or insulin Lispro. The onset for it is 15 to 30 minutes, so patients should be eating pretty quickly as soon as this has been administered. You have a peak time of 0.5 hours to 2.5, and the duration of this insulin is 3 to 6.5 hours. A slower acting insulin, which is regular insulin, and regular insulin can only be given IV, or it also can be given subcutaneous, but this is the only insulin that goes intravenously, and those are typically given in the ER or the ICU. But regular insulin, the onset of it is 30 to 60 minutes, it peaks to 1 to 5 hours, and it lasts 6 to 10 hours. Intermediate duration medication or insulin is your Detamir or Levemir, and that onset of that is 60 to 120 minutes. The peak is to 8 hours, and the duration lasts for 12 to 24 hours. However, there is a discrepancy in your Med Surg book. It says that this is a long-acting insulin. So I'm going to go with the pharmacology book, and that's what we're going to state it as. Long-duration medication, insulin glargine, and that is Lantus. The onset of Lantus is 70 minutes, and it has no peak, and it lasts 24 hours. I'm going to discuss shortly about mixing insulin. This is something you probably may never do, but it will be most likely on your NCLEX, so it's important to know. So we're always going to drop the clear first, always. So your clear is your fast acting, and then you are going to drop your cloudy. So always think of clear before cloudy. So cloudy is your long acting or your basal insulin. This is done to prevent contaminating, and you should always give your insulin within 15 minutes of mixing. That way you have onset, peak, and duration time. You don't mess those up. So that's all you really need to know about mixing insulin. So oral anti-diabetic drugs, also known as hypoglycemic agents, are prescribed for patients with type 2 diabetes who meet the following criteria. They must have a fasting blood glucose less than 200. Their insulin requirement is less than 40 units a day. They have no ketoacidosis or no renal or hepatic liver disease. The sulfonylureas and the meglitinides stimulate beta cells in the pancreas to remove more insulin. These are known as insulin releasers, and these are considered, other names for them are glimepiride, glipizide, glipuride, repaglinide, and negteglinide. Biguanides and thiazolinonides, which also are metformin, pioglitazone, and rosiglitazone, help the tissue use available insulin more efficiently, and these are known as insulin sensitizers. Drugs in this category, again, like I said, metformin, also known as glucophage, and this can cause upset stomach, flatulence, and loose stools. Again, metformin, glucophage, which can cause upset stomach, flatulence, and loose stools. The dipeptidyl peptidase, the DPP4 inhibitors, are known as sitagliptin and saxagliptin and linagliptin. Then we have the alpha-glucosidase inhibitors, and that is acarbose and migitol. Again, there are many oral anti-diabetic agents out there for these patients, and they work by different means. Adjuvant drugs for diabetes type 2, we have primlinitide and Simlin, which is a synthetic form of hormone, amylin, which is produced along with insulin by the beta cells in the pancreas. Amylin lowers blood sugar after meals and causes a sense of satiety that controls overeating. So the patient feels full, or they've eaten enough so they don't overeat. Then we have exenatide, which is Byetta. This is for the treatment of type 2 diabetes, which mimics incretin. Incretin promotes the secretion of insulin and improves the metabolism of carbohydrates. Then we have a combination med used as an adjunct to diet and exercise, and that is metformin and sitagliptin, and that is known as Janumet. So pancreas transplantation for the diabetic patient. These patients are type 1 diabetic patients with renal failure. They will be on lifelong immunosuppressive therapy. This involves replacing the pancreas, either the whole pancreas or a partial transplant. And you can view the figure on figure 51.9 on page 870 to kind of have an idea of that. There is a lot of risk versus benefit over this, and survival rates are somewhat poor. According to the national level, at 60 months, which is 5 years, you have a 48.3% of survival. At 12 months, which is 1 year, you have a 75.4% of survival. So again, the survival rates for this procedure are pretty poor. But it is an option out there, and many experts believe that the risks involved with the immunosuppression outweigh the benefit that can be achieved with a pancreas transplant, unless a kidney transplant is also necessary too. So, important to know. So the islet cell transplantation is another option, which is a better option. We're not actually taking a full or partial organ out. We're actually taking the islet cells and out of the donor, and we are placing them into the recipient, and they basically travel back and go where they need to go. This is a better option. However, the patient will still need lifelong immunosuppressive therapy, and the supply is pretty limited for this procedure. Typically, you need one, if not more, 2 donors to 1 recipient. So these are basically, the islet cells are transplanted. They need to be done immediately, and they are injected through the abdomen wall into the client's portal vein, where they eventually migrate to the liver and begin to release insulin. In order to prevent rejection, they have found that physicians are using a combination of Prograf, Rapamune, and Zenapax, again, to prevent rejection. But again, this is lifelong immunosuppressive therapy that you have to be pretty compliant with. So risk versus benefit again. And this can be viewed at on page 871.